Hi everyone, and welcome to the Documentation Electronic Health Records and Reporting lecture. Nurses are largely responsible for coordinating the patient's care, implementing the plan for nursing care, and documenting the patient's care and progress toward goals. As a result, nurses spend considerable time doing information work, things like accessing, generating, and sharing information to ensure that appropriate, accurate information is available to all members of the healthcare team. Healthcare documentation is any written or electronically generated information about a patient that describes the patient's health, and the care and services provided, including the dates of care. These records may be paper or electronic documents, such as electronic medical records, faxes, emails, audio tapes, videotapes, and images. The primary purpose of healthcare documentation and record-keeping systems is facilitation of information flow that supports the continuity, quality, and safety of care. The goal in documenting care is to describe the facts clearly and concisely to improve interdisciplinary and interdisciplinary communication. Now, in the classroom, we're going to go over some things because we want to make sure that you all know to document for the next shift or the next people reading it, not just for yourself. It's often clear in your head, but it's not always clear in someone else's head. So we'll do some practicing in class. Standards for documentation are established by each healthcare organization's policies and procedures. You'll hear that a lot this semester about policies and procedures. They should be in agreement with the Joint Commission standards and elements of performance, including having a medical record for each patient that is accessed only by authorized personnel. General principles of medical record documentation from the CMMS include the need for completeness and legibility, the reasons for each patient encounter, including assessments and diagnosis and the plan of care, the patient's progress, and any changes in diagnosis and treatment. The American Nurses Association has identified principles of nursing documentation related to the characteristics of documentation, education and training, policies and procedures, protection systems, entries, and standardized terminologies. The ANA's model for high-quality nursing documentation reflects the nursing process and includes accessibility, accuracy, relevance, audibility, thoughtfulness, timeliness, and retrievability. Accurate documentation is necessary for hospitals to be reimbursed according to diagnostic-related groups, or DRGs. You'll hear a lot about that in your career as well. DRGs are a system used to classify hospital admissions. Each DRG is reimbursed at a specific rate, and payment is often based on the documentation supporting the hospital stay. The medical record serves as the major communication tool between staff members and a single data access point for everyone involved in the patient's care. Remember that it's a single data access point for everyone involved in the patient's care. It's a legal document that must meet guidelines for completeness, accuracy, timeliness, accessibility, and authenticity. The medical record promotes continuity of care and ensures that patients receive appropriate healthcare services. The record can be used to assess quality of care measures, determine the medical necessity of healthcare services, support reimbursement claims, and protect healthcare providers, patients, and others in legal matters, and we'll have a whole class on that. It's a clinical data archive. The medical record serves as a tool for biomedical research and provider education, collection of statistical data for government and other agencies, maintenance of compliance with external regulatory bodies, and establishment of policies and regulations for standards of care. On this slide, we're just going to go down the list. The medical record is the legal documentation of care provided to a patient. If you didn't chart it, it wasn't done. Even if you did it, if you didn't chart it and it goes to court, it didn't happen. So in the event of litigation, the medical record is often the only available evidence of the event in question. And in our legal class, I'll have a lot of documentation examples for you that will show that. But if a patient says, you know what, or a patient's family, let's say, tells you that he died and he had a big mucus plug in his trach, and it only shows that a nurse actually suctioned his trach once and that he complained several times that he had trouble breathing, guess what's going to happen in court? Let's just say she did suction that trach every couple of hours, but if she didn't chart it, She has no way to prove that. Medical record documentation should be based on fact, not opinions. That's a big one. I'm also kind of a stickler for not writing patient complains of. I prefer patient reports. Someone once said to me in a conference, when you write patient complains of, you're now labeling them a complainer. So try to avoid complains of. You can say they report pain of 7 on a scale of 0 to 10. You can say patient reports trouble breathing, patient reports anything, but let's kind of stick to that. We also don't want to use opinions. If you say the patient was grumpy, that's not good. Don't chart what you thought the patient was. Chart that the patient was loud, the patient yelled at you, the patient stated that you were a bad nurse because you were 5 minutes later than you were yesterday. Whatever it is, you want to chart the facts, not the opinions. Every note in a medical record must include a date, time, and signature with credentials. So you can't just say, patient did blah, 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 and a date. That's not going to cut it. You have to have a time, and you have to have a signature with credentials. Ethical practice dictates that nurses document only interventions that are performed. Again, you cannot chart anything that you didn't do, and that includes another nurse. If another nurse comes out of your patient's room and said, I did blah, 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 can you just chart that for me? The answer is no. That nurse needs to go and chart it herself or hisself. Medical record entries cannot be altered or obliterated. Now, some of you who work in hospitals already know that a medical record an electronic one, can be changed. However, it leaves an imprint that it was changed. So it's really a big deal because in court, they're going to say, why was this changed and what were you hiding? So you want to avoid that at all costs. You would go in and put in a note that says something different. And every facility is going to have their own policy, but you want to be very careful that you don't alter or obliterate them because that looks very bad. So the paper-based medical record has served clinical practice for many years. It's all I knew when I started nursing. But the formal structure of the information within the record has changed significantly over time. It's moved from an unstructured or semi-structured chronological record of events to a problem or task-oriented structure. It may be difficult to locate a particular chart because it's being used by someone else, it's in a different department, or it's misfiled. So definitely some challenges to finding those paper charts. The paper chart is available to only one person at a time. Entries into paper medical records are traditionally made with black ink to enable copying or scanning unless a facility requires or allows a different color. The date, time, and signature with credentials of the person writing the entry are included in the entry, and no blank spaces are left between entries because they could allow someone to add a note out of sequence, which, let me tell you, it's happened many times, and it is the biggest pain in the tush you've ever seen. Not to mention, if that case were to go to court for some crazy reason, it doesn't look good. So the electronic medical record, or EMR, is a record of one episode of care, such as an inpatient stay or an outpatient appointment. The electronic health record, or EHR, is a longitudinal record of health that includes the information from inpatient and outpatient episodes of health care from one or more care settings. In the American Recovery and Reinvestment Act of 2009, the government mandates the use of a certified EHR for each person in the U.S. by the year 2014, so we know that had to have or should have occurred. Although the EHR varies among health facilities, the major components of health information are health information, diagnostic test results, an order entry system, and decision support. So what type of information is included in health information? That's something I want you guys to be thinking about. Health information comprises patient data, such as demographics, assessment findings, flow sheets that include point-of-care results, diagnosis, nursing treatments, and a medication profile listing historical and currently active medication orders. The nursing process is integrated in the EHR through documentation related to each of the 5 steps, which are, of course, the assessment, diagnosis, planning, implementation, and evaluation of the nursing process. Diagnostic findings include current and historical results from procedures, laboratory tests, and x-rays. So all of that is included in health information. Computerized provider order entry allows clinicians to enter orders in a computer that are sent directly to the appropriate department. Decision support in the electronic record may include medication interaction screening and reminders for preventative health actions, such as vaccinations. More sophisticated decision support systems assist the diagnostic process and include recommendations for treatment. The electronic record provides connectivity to enhance communication between all members of the healthcare team, who can access and update the record simultaneously. That simultaneously is a key. That's really nice. Adoption of an EHR system produces major cost savings through gains in productivity and error reduction, which ultimately improves patient health status. Please keep in mind that electronic health records do not eliminate errors. They help minimize them. The most common benefits of electronic records are increased delivery of guidance-based care, better monitoring, reduced medication errors, remember again, not absent, but reduced, and decreased use of care. Use of EHRs can reduce storage space, allow simultaneous access by multiple users, facilitate easy duplication for sharing or backup, and increase portability in environments using wireless systems and handheld systems. Some of you may have been to the doctor's office recently and see that they come in with handheld devices. You'll also see in your clinical this semester where nurses are on the computer, but you also need to access it for your information, and thankfully you're able to do that from a different computer so that we don't have to wait until the nurses are all through. Now, although data are often entered by keyboard, they can also be entered by means of a dictated voice recording, light pens, and handwriting and pattern recognition systems. Computer programs can convert these types of data entry into text. The EHR supports administrative processes with more efficient and timely data abstraction for scheduling, billing, and claims management. So you can see where they've done a lot for nursing throughout the years. Physicians, nurse practitioners, nurses, medical assistants, physician's assistants, UAP, social workers, and therapists may contribute to the EHR. Check the facility policy for documentation guidelines. That's a big deal because everybody's going to have something a little bit different. Now, laboratory data and other test results are available in inpatient and outpatient settings so that care decisions can be made. In some circumstances, care such as taking vital signs, assisting with activities of daily living, and documenting their outcomes can be delegated to the unlicensed assisted personnel. As more healthcare facilities implement EHRs and EMRs, the quality of nursing documentation improves, enhancing patient safety and communication with other providers. However, implementation of electronic records does involve a learning curve as staff become accustomed to the new system. Consideration must be given to how the new system fits into the existing workflow. The nurse must have a basic level of computer competency in addition to an understanding of documentation principles. Disadvantages of use of computers for documentation include computer and software failure and problems if there's a power outage. Therefore, any facility using EHR system must have computer support and maintenance available at all times, and have a backup plan in place in the event of a power outage. Access to an EHR is controlled through assignment of individual passwords and verification codes that identify people who have the right to enter the record. Passwords should never be shared with anyone. Healthcare information systems have the ability to track who uses the system and which records are accessed. These organizational tools contribute to the protection of personal health information. So remember that both in your field and out in your clinical situation. If you don't have a need to be in somebody's chart, don't. People have left this program because they were in charts they should not have been in. And if you're unsure, just go to your instructor. And same with once you start working as a nurse. That it was in the paper not long ago that a nurse lost her job because she had accessed 800 charts that she had no business being in. How she had time to access 800 charts is beyond me, but she lost her job over it. So be really careful that you have a need to know when you're getting into charts. At this point, I'm going to stop this part of the lecture, and the second part is going to be separate, but it will be posted for you as well.